pleasure is to invite here the Associated Professor of Obstetrics and Gynecology at the University of Rome, Professor Caterina Exacoustos. Her main areas of interest are endometriosis and benign diseases, including uterine pathology and infertility.
So good morning to all, and I'm happy to share with you my experience on adenomyosis, and I hope that, okay, I don't have the mouse here, sorry, okay. And so the problem is that our kingdom showed you yesterday that we can diagnose adenomyosis. And if you see this picture, you can see that all of you now can say that this is adenomyosis. But in the past, this was not the case, because these are seen as adenomyomas, or it's seen as fibroids, go to surgery, and it was a disaster because the stitches are on a myometrium that was not healthy. So we understand yesterday that we have direct signs which are very, very specific for adenomyosis, which are the cystic areas, the hypogonadogenic islands, and the buds and lines in the junctional zone. We have also indirect signs, and you heard before yesterday from Margit Duholm that it is better to have more signs together to make a diagnosis. But in fact, only direct signs, that mean only the asymmetry, are not specific, and you cannot do the diagnosis on this. So these are the direct signs to get together with indirect signs. But I want to show you why I think that the cystic areas are the most important signs that we need. Because you see that there is the gland inside the myometrium with a hyperechoic tissue around. So you can understand that this is endometrium inside the myometrium. And we need color Doppler mostly to distinguish fibroids from adenomyosis, but we need also to understand that adenomyosis with these cystic areas, we need color to differentiate them from vessels. But you can also see how much vessels you can find in an adenomyotic uterus, because there is an inflammation, there is a fibrotic tissue, which is very inflamed. And finally, you heard that we can see the junctional zone, and we can study it very accurately by ultrasound. And I like also to share with you the dynamicity of the ultrasound, because the ultrasound is not only a picture, but is a dynamic examination and give you the possibility to see these contractions. And now we have studies that show these contractions, that these are altered if we have alteration of the junctional zone. We have it proven. Pay attention again to make the diagnosis only on asymmetry, because this uterus was after 15 minutes a normal uterus because it was a contraction. Pay attention to make the diagnosis in the hormonal treatment, in a contraceptive pill, because the myometrium is much more dense and you can do the diagnosis. So do the diagnosis, please, with direct signs and not on hormonal treatment. But finally, if you all see these two types of uterus, you only agree that they have direct signs, but you cannot say that these adenomyosis are similar, because they are different. And they are different because direct signs are there, but they are focal adenomyosis and the other is diffuse. Look to the junctional zone, the diffuse one, and you look to the very, very focal adenomyosis in the junctional zone. So we understand, and I'm happy to hear the lessons before, that adenomyosis is not always the same. We have a diffuse one, we have a focal one, and then we have the adenomyomas. And adenomyomas had a circular hypertrophic myometrium around that give us the impression that there is a myoma, but they are adenomyosis, adenomyomas, which are these cystic areas inside and this hypertrophic endometrium. So you understand that we cannot say, and I hate when you said, she had adenomyosis, she had endometriosis. Endometriosis is not the same because we know endometrioma is quite different from a deep endometriosis. She had the fibroids. Fibroids are not all the same. While we have not to describe adenomyosis and inside the uterus as we describe fibroids. So we have to look to locations, we have to look to the type, we have to look which myometrial layer is affected. If we do this for fibroids, why not for adenomyosis? If it's diffuse of the inner layer of the outer layer, it has to be a different impact. So this type of adenomyosis, focal of the external layer, is different from the focal of the internal layer. So all of you, most of you who go to IVF with this uterus think that this uterus is normal. Look to the junctional zone. The junctional zone is not normal because it has not the gate halo. It has interruption. And if you saw 3D, you see this stripe here because 3D gives you not only the view of coronal section, but it gives you a lot of other information. So please go and see the junctional zone. And finally, we want also to have an extension inside the disease. And if you see this second Musa paper, it gives us all these steps how we can see adenomyosis and also to say the extension. And we also try to make this with a classification, so with a scoring system, just to say if there is a mild adenomyosis or a severe adenomyosis. And I think also that there is a correlation to pathogenesis because we know that this adenomyosis that comes from the infiltration of the endometrium inside the myometrium can look like this. Then we have the metaplasia hypothesis, and we can see that there is no connection with the endometrium in this case. And finally, we have the endometriosis and adenomyosis, which is associated with the famous, which we call it this question sign. The uterus is attached with adenomyosis and to deep endometriosis. And we know that we have endometriosis and adenomyosis, especially deep endometriosis, is correlated. So when you see this uterus, and you see that this cavity is normal, but look at the uterus and look at the adenomyosis and look how it is attached to the pelvic deep endometriosis. So if this woman does not conceive, there is a problem not only of the cavity, but it's a problem of the uterus and all the pelvis and all their anatomy. So again, if we have correlation to pathogenesis, we have correlation to symptoms. And there are the first papers coming from UK. Say us, if we have a lot of features, we correlate it with menstrual pain or menorrhagia, but features are not enough because we have here a lot of features. We have cystic areas, striation, hyperechoic, but we have to look also to an extension inside the uterus. And so what we show is, according to our classification, that this type of diffuse adenomyosis was much more in patients who are older, which have heavy menstrual bleeding and dysmenorrhea, but this type of focal adenomyosis, especially of the inner myometrium, are correlated with infertility. And again, I want only to stress that we saw adenomyosis in this case also in adolescents. And you see that 5% of adolescents in our group had adenomyosis, and if they had dysmenorrhea, it was 9%. So don't understand that you will see adenomyosis in adolescents like this huge uterus. They are small signs, small direct signs, and it's a very mild adenomyosis. Regarding infertility, this is our last paper. So what we do is we test patients with adenomyosis who are going to IVF and with egg donation. So that we try to have a good embryo and for the analysis. This was a prospective study, so we have patients with adenomyosis and patients with control, and they are blind. So the diagnosis was blind on, I get the videos, I get the volumes, I get all, and I make my diagnosis. And I don't know the results of IVF. So you can see that there is, on implantation rate, not differences, because both had a 15% of implantation rate, but you can see that the miscarriage rate in the adenomyosis group is much more higher. So when we look to implantation rate, clinical pregnancy rate, or live birth rate, the only significant testing is that they have much more miscarriage. But if you see the miscarriage where there are more is in the severe one, but in all patients who had adenomyosis in the inner myometrium. So junctional zone, and especially if they are diffuse in the junctional zone. Whereas if you have adenomyosis only in the outer myometrium, you have an ongoing pregnancy. So again, you will see that there is something different from the location and type of adenomyosis regarding adenomyosis. And the same, this is in a very, very recent paper that we do on recurrent miscarriage, and also here comparing patients with recurrent miscarriage and adenomyosis and a recurrent miscarriage without adenomyosis, we show at first that who had adenomyosis had much more numbers of miscarriage. And again, we show that in patients with recurrent abortion and adenomyosis, the inner myometrium was much more affected than the outer myometrium. And finally, I want to stress also to the IVF people that adenomyosis is not only the implantation rate, but there are complications in pregnancy. And we have to say this to the patient. If the patient had adenomyosis, she has to know that she had a major risk of preterm delivery or complication during pregnancy. And if we again make the diagnosis before pregnancy, in this case of adenomyosis, and we compared it before pregnancy without adenomyosis, we see a higher number of placenta previa, gestational hypertension, and we see also C-section and postpartum hemorrhage. But again, when we look to the outer myometrium or the junctional zone, we see that the complications are different, because if we have some in the junctional zone, adenomyosis is much more fetal growth restriction. If we have more in the outer myometrium, it's much more postmenopausal miscarriage. And this is why, because these are two different myometrium. So very briefly, I want to share another problem is that we have with the magnetic resonance. So we don't see the same things, despite we have the similar sensitivity and specificity in diagnosing adenomyosis. So we heard yesterday that junctional zone has a different appearance, and it has. And we know that magnetic resonance gives us also classification, and this is one of they use it more, and you can see they also make focal adenomyosis, internal adenomyosis, and the diffuse adenomyosis. However, we are not speaking the same languages. This is for radiologists adenomyoma. For me, for our ultrasound kingdom, this is a diffuse adenomyosis of the posterior wall. This is for radiologists a focal adenomyosis because it's attached to the deep endometriosis. For us, it's a diffuse adenomyosis of the posterior wall, and you know when you have a surgery on this, you have a lot of problems to detach the deep endometriosis from the adenomyosis. Again, This is not an adenomyoma for us, this is a diffuse adenomyosis of the fundus. So unfortunately, we are not speaking the same languages, and therefore a lot of papers that said adenomyosis yes, adenomyosis no, and there are different imaging are not comparable. And this is why I think we have to work a lot to make this type of diagnosis a little bit comparable. We are only think that there is the presence or absence of adenomyosis. So I hope that I show you that adenomyosis is not always the same. We have different type, and we have to think that adenomyosis has to be described inside the uterus. And some years ago, with my colleague, Professor Zuppi, we start to have and said there is a new era to diagnose adenomyosis. At first, because we have an ultrasound image, which is easy to have in every office. But we have to understand that we need no more the histological gold standard, and therefore we can study also in young patients. And I said you, problem on histology, last week I have a rejection of my papers that said because I have no histology on endometrium in adolescents. And despite we know that we have a very accurate ultrasound diagnosis. And so we cannot admit anymore that we ask for histology in adenomyosis. Thank you for attention.